You can see if they actually participate in weighing themselves. Okay, Mr. Jones is gaining weight here. We need to get him on the phone. What are you doing? Stop eating the hot dogs. But you intervene early before they end up in the ED, and then hopefully before they end up in the hospital. And a lot of studies have shown that it's very effective.
Hello and welcome to the Healthtech Marketing Podcast, brought to you by HealthLaunchpad and HIMSS. Thank you for joining us today. I'm Adam Chirinas. I'm the CEO and founder of HealthLaunchpad, and I'm your host. So marketing to healthcare is really hard, and we could all use a little help. So the Healthtech Marketing Podcast is a chance from you to hear from experts in the field, people who are either marketing to healthcare organizations or people at healthcare organizations who can share insights about best practice and how to market and sell to them. And so the aim of this show is to give you practical advice, things that you could apply today to improve your sales and marketing. So this pod is brought to you by HIMSS, global advisor, thought leader, and the leading member organization who's committed to transforming the healthcare ecosystem. It's also brought to you by HealthLaunchpad, a marketing consultancy that specializes in helping healthcare technology marketers grow their business. Today, I'm delighted to introduce you to our guest, Dr. Jordan Tannenbaum. Jordan is VP, CIO and CMIO at St. Peter's Healthcare System in New Brunswick, New Jersey. So, Jordan, you're one of the few people who's truly, almost, I hate to almost say a polymath. You're both an MD, you hold an MBA and an MPH. And I think it'd be fascinating to start off with. Tell us about your story, about how you started in healthcare and then your transition into the technology space.
Thank you, Adam, and thank you for having me today. So I am a pediatrician. I went to medical school, decided to become a pediatrician, opened my own practice back in 1982. And I was in practice for half that time in private practice. And then as the trend went, we sold our practice to the hospital, and I worked as a practice leader and continuing my practice for a total of 30 years. And then at the end of 30 years, the first patient I ever touched, who I ever delivered, I wasn't delivering the patient, but I was there for the birth. He came in with his baby. And I decided that it was time to retire. During the end of the year as a pediatrician, however, my CEO, way before meaningful use, foresaw the advent of the EHR and wanted to get our hospital on an EHR early, and went ahead and purchased the product. And since I was one of the few people in the hospital at that time who knew what a mouse was and understood, a little bit about computers, he says, "You're going to be the one who helps us roll this out." So we started, rolling it out on the inpatient side. We bought an outpatient product. We went through all the practices and did that. And I developed at that hospital what was then becoming the CMIO role, the Chief Medical Information Officer. So I ended up leaving at that time, at the end of my 30 years, not only having a 30-year career in pediatrics, but having about a 4-year career implementing EHRs and, having served as an early Chief Medical Information Officer. But I was not ready to retire and was interested in still working in industry, and was able to procure a job with our vendor, who at that time was McKesson.
Yeah.
And I worked for McKesson for 4 years as a physician executive. And in that role, what I did was, my initial role was demos and sales. So I was on the sales team, and we used to go to hospitals and demo the product. And then they shifted us to more of a consultancy. And I was doing interim CMIO roles across the country. They would send me to hospitals all around.
Interesting.
Implementation or optimization.
Yeah.
One of the hospitals I ended up being sent to was here at St. Peter's, where I worked as a consultant for a year, because their CMIO had left. And at that time, McKesson had was in the process of selling their IT division.
Yes.
And it just worked out. They offered me the CMIO job. I didn't know what was happening on the other end. I'm sure it would have been fine either way, but I decided to, take the CMIO job. 4 months after I took the CMIO job, there was a reorganization in one of those complete reorganizations of senior staff, and I was tapped to be the CIO. So I inherited the CMIO job and the CIO job, and that's been the same for the last 4 years. So I've had a steep learning curve. I am fortunate to have an excellent crew beneath me. I have a great department, and they really supported this decision and, taught me a lot on the CIO side, and, we worked very well together. So that's where we stand today. That's how I got here.
What a fascinating journey. So let's change gears a bit and talk about your healthcare system. So, St. Peter's is in a pretty busy, busy market. Also very, they're also competitive market from a healthcare system. But, we've all been dealing with one of the most serious events in a generation. So I'm really curious to know, so how has St. Peter's coped with the pandemic, and but maybe more pertinent is what's been the role of technology in helping sort of get through this?
So we're about a 478 bed teaching hospital. We have one hospital and several outpatient clinics. Before the pandemic, we had about 20,000 admissions a year. We had about 65 to 70,000 admission visits to the ED. We have a medical staff of 1,000, of which 250 are active at the hospital per se. So that's kind of the quick overview of where we are. So when the pandemic hit, we saw, New Jersey was one of the early epicenters. It was out west, if you remember, and then right into the tri-state area. And so we're all learning as we went, and as one of our other vice presidents says, we're building the plane as we're flying it. And that was very true for a lot of hospitals early in the pandemic. Yeah. I think our response was quick and decisive. We cut off all other care that was non-urgent. We formed teams to do specific functions. People were redeployed to do specific functions, and made sure that the patients were being taken care of as best we could within the context of what we understood the disease at that time. So where did IT came in? Well, IT actually came in a lot of ways. So the first thing that happened was, okay, if you're not necessary to do care here, if your job does not require your body in person, we want you remote. There's no reason to be in the hospital. At that time, we didn't understand the contagion very well. We were trying to limit exposure. So everybody had to go remote. Well, fortunately, we had two things in place already. One is Zoom, okay? Yeah. But the other was we had started our migration to Teams, Microsoft Teams. So we had Teams in place, especially for the IT group. So the IT group, on literally a day's notice, went totally remote seamlessly, because they were already equipped with laptops. They had the VPN connection, and we had both Teams and Zoom. So we were ready to go. So on a Tuesday, we said, go home and don't come back. And they never have. They're going to be permanently remote, those that can. Obviously, your desktop people and help desk people really, well, some help desk people can be, but we keep some of our help desk people on site. And all your desktop people have to type things. They're not remote, but everybody else went remote, and they've stayed remote. And we were in place and lucky that we had that kind of ready to go. So then we had to do that for other departments that weren't traditionally remote, particularly finance and many other departments. Your people who are doing the discharge planning, they need to look at the chart and make decisions, but they don't necessarily have to see the patient. So we got them remote, and they were able to work in the background, getting these people placed and discharged, which was very difficult. If you had a COVID patient that needed to be placed at that time, there was very little place to put them. So we got everybody remote. So that was the first thing we did. The second thing that happened was there was a lot of reporting. The HHS and New Jersey Department of Health wanted all this data. And fortunately, the New Jersey Hospital Association stepped up, established a portal that the hospitals in New Jersey all dumped their data into, and they sent it to whoever needed it. So all we had to do is go to their specs. Well, those specs changed every 2 weeks. So our decision support people, our report writing people were working literally around the clock, weekends, nights, to get the latest version of the data. And then there was all sorts of data definition problems, because in the beginning, what's a COVID patient, right? You know, a lot of people had, before we really defined the tests and the criteria, at first there wasn't even a code for COVID. There wasn't a diagnosis specifically for COVID. So how do you filter those patients out? What markers are you putting in the EMR? How are you going to use those markers to define a patient? How are you going to report on those patients? Or what things do you need to report? And the things that we needed to report, it, got broader and broader and changed rapidly. So the decision support team, I think, did a fantastic job keeping up with that, working really hard. Then the other thing that came up was remote monitoring of patients. Okay, so rather than having the nurse, in a traditional situation, the nurse will round on the patient every whatever the acuity of the patient is, check on the patient. And what the nursing asked us is, can you put remote monitoring cameras in the room and centralize the station where we can have 1 or 2 RNs? We want to be able to talk to the patient, and we want to be able to see the patient remotely.
So in the room, in the inpatient room or room at home? Oh, okay, yeah.
The patient. Yeah. So we built from scratch, we cobbled together these webcams on IV poles, sent them to a central station with multiple monitors, and we had an RN or 2 watching all the patients, and was able to communicate with the patients and allow the nurses who were very overwhelmed to do more direct nursing stuff and not have to just check on a patient. Then the sad thing was, of course, a lot of people, there were no visitors. Yeah. And, people were in their terminal stages alone. And I think this was just devastating. And we were tasked with getting some kind of communication between families and the person in the hospital. And, we came up with basically, a tablet solution, an iPad, basically establishing some kind of Zoom session with that. And that worked out as well. So those were some of the things we did that were immediate responses. And then from there, we've learned a lot of lessons about incident response and coordination and communication. And in fact, just the other day, we had kind of every few months we regroup and say, okay, what do we do right? What do we do wrong? And, one of the things that came up is, our incident response, which was very good, but was really phone-based, maybe could be Teams-based. And maybe we should do that. What are we doing for communications? As you are well aware, we have a texting solution. So did we leverage that enough? Could we have expanded that use? So there's always a lot to think about. Of course, after it's over, you learn, and that's the idea. If you learn and implement what you think is the right thing, it's a horrible thing to go to, but the next thing that comes, maybe you'll be a little more prepared. That's what we. One of the.
Thank you. Yeah, and as you.
Adam, one other large thing, I need to interrupt you, but telehealth.
Yes.
Okay, so telehealth was huge, and we were doing a little bit of telehealth. We had actually established a telehealth solution, and then the CMS said, "Look, you don't have to use an approved HIPAA telehealth solution. You can use FaceTime or Google Duo, whatever you want." Those products, although great for consumers, were not great for telehealth because the patient had to load an app, the provider had to load the app, and the patient and provider knew each other. The doctors, the patient could call back.
Right.
It wasn't good. So we went with a temporary solution that we found, and then our EHR vendor quickly incorporated telehealth into their product, which was terrific, and we started using that. So, our telehealth, and I'm sure you'll hear this throughout the industry. I know on other things I've been on, listening to people, telehealth just took the boom. It just floated and showed its benefit that we all knew was sitting there. That was
it's fascinating how it's become an accelerator for telehealth and remote patient monitoring and other things like that, AI as well, I've heard. But and as you now look ahead, you've taken stock of some of the lessons. We're not out of the woods yet, but I'm sure you're kind of looking ahead over the horizon. So how is it changing your priorities as an organization? And then, how does that affect your technology decisions?
Right. So I think going back to the telehealth, that's one of the biggest things. Now, we were all, I know on the technological side, I think most of us knew what telehealth could do. But we were held back from reimbursement considerations, especially from CMS. For instance, in Medicare, before COVID, unless the patient is in a designated rural area, you really couldn't be paid for telehealth. Well, nowhere in New Jersey is a designated rural area. We have a lot of farms,
right? But
it wasn't really a true designated rural area. So then when they opened it up and we were able to do all this care, it became evident, and Seema Verma said it herself, the genie's out of the bottle. We saw the power of telehealth. And I think that's one thing that's carried over. We were doing, maybe dozens of telehealth visits a month before COVID. Then we were doing like thousands of telehealth visits during COVID. Now we're down to hundreds, but we want to expand that. We really think that that's the market that we can really expand value to the patient and ourselves with more telehealth and more focused telehealth and more mature telehealth. So we're looking at that.
What do you think mature telehealth means? That's it's really interesting. I've never heard anybody say that.
So mature telehealth is using telehealth in the right context, right? So as a physician, that at some point you probably have to examine the patient. So you can't do telehealth for everything. Right. But there's a lot of things you can use telehealth for: low acuity, acute care, and follow-up care. To be able to say to somebody who you don't need to see in person for follow-up, but you'd like to talk to them and work through how they're doing, you can do that in some cases as follow-up. And, many of us did that on the phone, and you didn't get paid for that. If you do it as a telehealth visit, you're going to get paid if the current reimbursement system stays. So that's another element. And then we didn't get into remote patient monitoring as much as some of our peers did. But I think that is definitely, we were going in that direction before COVID, and we hadn't gotten there. Had we gotten there, we would have done a lot better on the discharges, getting them out earlier and being able to monitor them at home. But that is another area where there's a lot of value in the right patient, people with, congestive heart failure, COPD, how are they doing? And then, you get the electronic scale and you can see if they actually participate in weighing themselves. Okay, Mr. Jones is gaining weight here. We need to get him on the phone. What are you doing? Stop eating the hot dogs. But you intervene early before they end up in the ED, and then hopefully before they end up in the hospital. And a lot of studies have shown that it's very effective. So I think that's the deficit that we have, that we don't have that capability quite yet. It requires a lot of back infrastructure. Who's monitoring all that data? How are you filtering the data? What's the escalation path? There's a lot of infrastructure. We're not there yet. We're getting there. We're doing actually an inpatient pilot on this, which is a whole nother topic to talk about. But we're getting there. We're getting there. And I think a lot of organizations who are there found a lot of value in that as well.
It's truly interesting seeing how, if there's anything good that could possibly be described, I mean, if you can ever use the word good related with COVID, but the only positive thing is that it has sort of got healthcare organizations kind of over a big hurdle in terms of implementing a lot of the things that we've been talking about for a decade.
Correct.
A lot of these things have sort of been there in theory and the shift to value-based care, but it sort of feels like this has actually been a forcing function to really get organizations moving towards it, because, the benefits to the patients are there, the benefits to the healthcare system, the benefits to the providers. And, it's maybe that's the one positive thing will come out of this. I want to change tacks and talk about what it's like being a buyer and an influencer. So when, a lot of the people who listen to this podcast are marketing and sales folks who are trying to figure out how can they engage with folks like yourself in a respectful way that you actually appreciate and want to actually talk with them, as opposed to sort of, the opposite. What's it? Tell us first of all, sort of like, what's it like? What's your inbox look like? What does it feel like to be marketed at?
Well, yes. I mean, Adam, that's a great point, because most of my email, especially external email, is marketing. Let's call it cold calling or cold emailing.
Yeah.
About different products. And, there's different approaches, as you well know, to how they try to get your attention. Some people call the office. It's a constant struggle to really balance, looking at that. And to be fair, a lot of the things that we get marketed to are about, we already have a solution. We're not in the market for it. We're not going anywhere. Once in a while, and I'm going to say 4 times a year, somebody hits me and say, wow, I ought to contact that person because A, that's a problem we are trying to solve, or B, I had no idea that was in the market, that was a solution, because you just told me I had a problem that I didn't know I had. Or 3, I'm unhappy with what I'm doing now, and maybe what you're selling sounds like what I need. But you have to tell me, exactly, although healthcare is really behind in technology, I think we can all agree. I mean, if you look at most other fields, adoption of technology, especially digital consumer-facing technology, we are behind. But we also do have a lot of technology in place. So you can bet on whatever you're trying to sell me, I probably have. And the fact that you do it isn't enough. You need to tell me how you're better than your competitor, or how you're better than the standard solutions in your space that will get my attention. To say, hey, we know how to collect bills, or we know how to do clinical notes. Well, okay, I got things doing that. Tell me what the benefit is against your competitors, against your space, even if it's cost. That's something that would probably get my attention.
So I had 3 things. So first of all, there's the, you get, I imagine that your email, you probably get 300 emails a day, right? So whatever it is, it's hundreds of emails. So over the course of a year, you're getting, thousands, tens of thousands of emails. Maybe 4 are like, yeah, I actually want to respond to those. Not a good hit rate. Number 2, something you said, which I thought was interesting, is that telling me about, you tell me about a problem I didn't know I had. That was really an interesting notion. Tell me a little bit more about that.
Well, sometimes, and I'm trying to think of an example, and I'm blocking right now, but sometimes, you say, this is what we do. And you're thinking, okay, I didn't know there was a much better way to do that. I didn't know there was any other way to do it except what you're doing. Okay, so let me give you, without mentioning names here, we have our usual process of sending bills and doing collections. And a lot of companies come out and say, we can improve, your collection rate. We can improve your turnaround. This company sent me a screenshot of just one screenshot. Says, we know that you have this EMR. We work with that EMR. And when a customer or patient comes to your practice, your registration people pull up this screen and have an entire one-shot picture of what's going on and can collect. And the screen was so compelling. And I said, I'm not the finance person, but I forwarded it to the finance person because we've been having discussions about how we're going to improve collections, how we're going to, decrease bad debt, all those usual conversations. I said, this looks like a tool that's so well put together and integrates into our EMR. What do you think? And, just the screenshot was enough to get a meeting together, which we just had. I don't know where they're going to go with it. Again, I don't know the value of the collection end, but that was something that solved this problem in a way that we would not have done.
Right.
We would not have thought about. And of course, all these companies, which rightly so, they start with one thing and they say, we can also do this, this, and this, and create this universe where these are connected products that work for you. Of course, that's what they want to do. They want to sell you more. That's okay. Right. I don't mind that as long as you're a solid company and you're showing me value. This is basic to any industry. You've got to show value to the buyer.
Yeah. And there's something about what those guys did where it felt like it was personalized to you. It was like they'd taken the time to say, we know you've got this EMR, and this is what your people see when they are going through doing collections or whatever it happens to be, whatever that financial task is. Really interesting. Sort of very much a sort of it got your attention because it solved a problem that's relevant. It did it in an insightful way, but it also felt personalized.
Yes.
Yeah. Really interesting. So, what are your pet peeves? What are if you could send, I don't know how many hundreds of thousands of marketers are listening to this, but if you could send them one message saying, please stop doing this, what would that be? Don't pretend we had an appointment that I missed. Oh. Somebody did that to me today, and I'm actually going to hold the appointment because I'm going to give them a lesson. That's hilarious. But that is, sorry we missed our call. Well, I try to be very diligent in all meetings and all my calls, and I do not like to have missed a meeting, and they know that. Yeah. But we never had a call. I don't know who you are. So don't do that, because you do that, I'm not going to you just tune yourself right out. It's actually insulting. Yeah, it insults your intelligence. And the other thing is, and this is just common for all, cold calling, an email for me is better than a call. I'm not going to take time out of my day to do a sales call from a cold caller. I'm just not. Right. And I try to tell people who call, they start their pitch and I say, listen, I really don't have time to talk to you right now. You have my email. Usually they have my email from whatever source. I said, just send me what you want me to look at. And, if I'm interested, I'll let you know. Otherwise, if you don't hear from me, I guarantee I'll look at your email. If you don't hear from me, I'm probably not interested at this point. And if I say I'm not interested, just leave me alone. If I say, please contact me in 6 months, which I do, I can't, I may be interested, but right now I'm too overwhelmed to deal with this, or we don't have the money, or whatever. But I might want your product in 6 months. Just put me in your Salesforce, whatever it is, in the CRM. Contact me in 6 months. So you moved from being a physician for 30 years to working for McKesson. When you switched over to sort of the vendor side, what was it what surprised you? And it was like, I don't know, it was like that here. What was it was there anything that just really kind of got you, really surprised you? Well, I'll tell you, it was a positive surprise. I was a little hesitant to go to the vendor side,
although I had never been on the buying side as a physician, in terms of technology, but I had worked closely with the CIO in my CMIO job. And I thought, oh, they're just going to, I'm going to be, a salesman, and I'm going to have to, go pitch and do. The company I work for was very sensitive to their customers and their potential customers. I don't feel like they did a hard push. Now, maybe that was happening outside of my environment. But when we came in to do what we did, and maybe we were later in the sales cycle, we were very much trying to come in as a full partner and to give you value where we thought you might need it, where you think you might need it. And it was very much of a positive experience. I would say 90% of the demos, we had a very good experience with the medical. I was dealing with the medical staff, which can be a tough customer, and some of the CIOs and some of the executives. We had a positive experience on these demos. We had a good conversation, and it wasn't a matter of you need to buy this. It's a matter of, we really think this might be a fit for you. What do you think? And if not, in some cases, the product really didn't fit, and we all moved on, and that was fine. And in some cases, we thought it would be a fit. Let's explore it further. So I guess my message, my surprise, if you're asking, was it wasn't a hard sell. It was a very mature process, and I know a lot of organizations do that. So I was pleasantly surprised that way. And I was also pleasantly surprised when customers had issues. The focus was the customer. Nobody wrote off the customer. We were sent literally on if a customer was having a serious issue from the physician side, something that we were involved in, we would be sent at a moment's notice. One morning, I got a call. We traveled back then before COVID. And
I remember those days.
I was sitting at home on a Tuesday morning, and I was scheduled to go that afternoon someplace else, and we get a call. This hospital is having a major issue. Can you get out? How soon, can you be at this place? How soon? And I'm, looking at the bookings. I said, well, I can make a flight in 2 hours. Okay, get on it, go. Or we're sending this person to meet him at this place, and we're going to take care of this. So they immediately responded by sending in the appropriate people when they could.
Very interesting. Really interesting to get that.
My experience on that end was positive. Yes, I understood the sales cycle and the funnel and the whole back end of making sales targets and all that. We weren't really in our division affected by that, but we were part of that sales team and saw how it worked. But it's very much I felt the customer centered experience, which was a pleasant surprise. And but I did understand the economics of you just can't sell something without making a profit.
Got it. It's really interesting perspective, that. Well, Jordan, it's been a great pleasure here having you today on this podcast. I mean, you've given us a lot to think about, so I really want to thank you for your time. Before we go, I do want to ask you though one last question, which is, if you could give the audience one piece of practical advice that they could act on today, what would that be? This would be something that you've learned in the last few years that you wish you'd known earlier.
Well, I think that's kind of a personal question.
I apologize.
I'm going to handle it. I was in practice for 30 years, but I always had this interest in computing and all these other things. But, I didn't pursue it because I was a physician. And I think if I was going to do something again, I would say extend yourself, take more risks. If you have that interest, just explore it and see where it goes. As you mentioned, I always thought I wanted an MBA, so I went and got an MBA. I didn't know what I was going to do with it, but actually it ended up helping. And then I got a clinical informatics degree, and then I got the Masters of Public Health and I got that before COVID. I got the Masters of Public Health because I felt like my medicine was moving in terms of addressing larger societal issues like social determinant of health. So I needed to get that. But I think had I moved earlier in my career towards my other interests, I think earlier in my career, I could have expanded the way I did now. And I think just take that jump, do what is in your heart, and do what you're passionate about. I can't say that enough. It's the same advice I gave my kids. I wish I had taken that earlier. So that's the one thing I would take away from my own retrospective view of myself.
I appreciate you sharing that. Thank you. That's a really great piece of insight and great piece of advice.
Thank you.
So also, I want to thank our listeners today for listening. And before you go, I just want to let you know that if you're not subscribing to this podcast already, you can subscribe on Apple or Spotify or other podcast channels. It's available across all channels. And you can also view the video to the show if you're not currently viewing the video. And there's a link on the show notes. We've got a great program of guests coming up, so I hope you will subscribe. And if you've got a topic that you want to cover, you can get hold of me directly. You can either email me at adam@healthlaunchpad.com. That's adam@healthlaunchpad.com, or you can find me on LinkedIn. I think I'm the only Adam Turinas out there. So thank you again to Dr. Jordan Tannenbaum. So appreciate your time today, and thank you all for listening.
Thank you, Adam. Had a great time.